It's time for the 3-question one for Renal 3. Let's get going. What pathology fits each of the following high-yield phrases? First one we have here is gout, mental retardation, and lip biting. That's going to be Lesch-Nyhan syndrome. Antihistone antibodies. That's going to be associated with drug-induced lupus. Samoma bodies. So remember, we use that mnemonic at the beginning of Samoma to remember this. So P is for papillary adenocarcinoma of the thyroid. S is for serous cisadenocarcinoma of the ovary. And then the M's are for meningioma and mesothelioma. Next, we have lytic bone lesions on X-ray. That's going to be seen with multiple myeloma. Next question. What are the toxins for strep pyogenes? So let's talk about, there are several of them here. There's streptolysin O, which causes hemolysis on blood agar plates, and it's oxygen labile. There's also streptolysin S, which is an oxygen stable one. There's also streptococcal pyrogenic exotoxins type A, B, and C. So these are also known as the erythrogenic toxins. Remember, these act as superantigens and are associated with the red rash and the fever of scarlet fever. You can also see this in that streptococcal toxic shock syndrome as well. Next question, what is HUS? So this is hemolytic uremic syndrome. It's associated with that E. coli O157H7, one of the serotypes of E. coli causing bloody diarrhea. So with HUS, you have hemolytic anemia, thrombocytopenia, and then acute renal failure. All right, guys, that's going to be it for the warm-up. Let's get to that lecture now.
My research has led me here to the nephron, just beyond the glomerulus. According to this map, if we follow this long, winding passage through the proximal convoluted tubule, down the loop of Henle, and then back up the thick ascending limb, we'll eventually make our way into the collecting system, where legends tell us we'll find a vast golden treasure. It could be dangerous, so stay close and watch your step. As we work our way through the nephron, we're mostly going to be looking at these complicated diagrams in the study guide, starting with number 4, which is the first half of the proximal convoluted tubule. Now this diagram is pretty busy, but I'll talk you through it step by step. This is the worst one, and they get easier after this, so stay with me. Fluid was filtered from the blood in the glomerulus, and the filtrate immediately enters the proximal tubule, which is the workhorse of the nephron. All of the glucose and amino acids are reabsorbed here. We covered that in Renal 2. And about 2/3 of the fluid and electrolytes that were filtered by the glomerulus are also reabsorbed by the proximal tubule, and the fluid that's reabsorbed here is reabsorbed isotonically. So the electrolytes are reabsorbed in the water just follows. Let's look at this diagram. Over here on the left side is the lumen of the tubule. It's yellow. I'll let that sink in for a moment. Yellow fluid in the kidney. Right. Then in the center of the diagram is the tubule cell, and the interstitium is on the right. So make sure you stay oriented as we go through these. The lumen is always on the left. Over on the right, moving from the tubule cell and the interstitium, you can see everything that's being reabsorbed from the filtrate and eventually put back into the circulation. So what are we reabsorbing here? Primarily bicarb and sodium. Now how is bicarb reabsorbed? Well, if you look inside the cell, you see carbonic anhydrase, which is creating bicarb from CO2 and water. Where does that CO2 and water come from? It comes from the lumen side. Bicarb in the filtrate is bound to hydrogen ions that come out of the cell, and that creates CO2 and water, which can move freely into the proximal tubule cell. Then carbonic anhydrase in the cell can convert that back to bicarb, which generates a hydrogen ion. That hydrogen then goes back into the lumen on the left. And over on the right, the bicarb is reabsorbed into the interstitium. And what's driving this reabsorptive process? Well, ultimately it's what drives everything in our bodies. It's the sodium-potassium ATPase up at the top right. Sodium-potassium ATPase uses energy to pump sodium into the interstitium against its concentration gradient. Now toward the bottom, you see that substance X is reabsorbed by a sodium cotransporter. And then X is crossing onto the interstitium side over on the right. Well, what's substance X? Well, it could be a lot of different things. It's your glucose, amino acid, inorganic phosphate, and lactate reabsorption. They're all driven by this sodium gradient. While we're here in the early part of the proximal tubule, let's talk about the relative concentrations of all these things as they're reabsorbed. So we're going to plot a graph, and our x-axis is going to be the distance along the proximal tubule. So over here at the y-intersect, you're at the headwaters of the proximal tubule, just outside the glomerulus. And on the far right, you're at the end of the proximal tubule, the beginning of the descending limb of the loop of Henle. And the y-axis is the ratio of tubular fluid to plasma. So for any given solute that you want to graph, the y-axis is the concentration of that solute within the tubular fluid in the lumen of the proximal tubule divided by the concentration of that same solute in the plasma. So if the concentration of the solute is the same in both the tubular fluid and the plasma, that ratio on the y-axis is going to be 1. In other words, the solute and water are reabsorbed at the same rate, and the relative concentrations aren't going to change. For solutes that fall below that line, the concentration in the tubular fluid is less than the concentration in the plasma. That means you're taking solute out of the tubular fluid, out of the lumen, and putting it into plasma. So you're reabsorbing it more quickly than you're reabsorbing water. Then above that line, the ratio is greater than 1, which means that solute is being reabsorbed less quickly than water. So you're pulling water out of the lumen, but the solute is staying in the lumen. There's a net excretion of solute there. So let's talk about what substances follow this pattern. The reabsorption of sodium and potassium don't change much from beginning to end, and osmolality doesn't change much from beginning to end. They're pretty flat. So you are reabsorbing sodium and potassium, but water is being reabsorbed at the same rate. It's isotonic reabsorption here in the proximal tubule. The relative concentration is staying constant. Inorganic phosphate is being reabsorbed more than water. The concentration of phosphate in the plasma is rising relative to the concentration of phosphate in the tubular fluid. So the kidney is actively pulling phosphate out of the tubular fluid, pumping it into the interstitium and then into the plasma. That was X at the bottom of number 4 in your study guide. X was inorganic phosphate, glucose, and amino acids, which look like this on the graph. Those are all things that your body wants to retain much more than water. Then, up top, what kinds of things does your body value less than water? Well, chloride is above the line. Urea is above the line. And then creatinine and inulin are up here also. Both creatinine and inulin are filtered, but we know that they're neither secreted into the tubular fluid nor reabsorbed by the tubules. Whatever amount of inulin and creatinine got filtered by the glomerulus is exactly how much is going to end up in the urine. No more, no less. So concentrations are going up, not because they're being secreted, but because water is getting reabsorbed. And as water gets reabsorbed, the concentrations of these substances increases. So any substance that graphs above that creatinine-inulin line is not only not getting reabsorbed, it's actually being actively secreted into the tubule. And that's why PAH actually has a higher concentration as you get farther along the tubule than either creatinine or inulin, because PAH is both filtered and actively secreted by the proximal tubule. Now, this is definitely an important topic to know. Be able to look at this graph and label substances on this graph. Be able to recall what creatinine looks like on this graph. Know where glucose and amino acids are on this graph. Very, very important to understand this for your test. All right, back to the nephron. Let's talk about the second half of your proximal tubule next, back in your study guide. Now we're on number 5. The second half of your proximal tubule is a little bit different than the first half. In the first half, sodium absorption was associated with bicarb absorption. But in the second half of the proximal tubule, sodium absorption is associated with chloride reabsorption. So you see sodium being reabsorbed, and you see chloride being reabsorbed. And that's pretty much it for this diagram. I told you it's going to get simpler after that first one. And again, you see that sodium and chloride reabsorption are driven by the sodium-potassium ATPase. Then number 6 deals with the active secretion of organic cations and anions in the proximal tubule. To secrete an anion, you use alpha-ketoglutarate. So we're starting on the right this time, out in the interstitium. Alpha-ketoglutarate is brought into the cell with sodium by way of a sodium gradient that's established by sodium-potassium ATPase. So alpha-ketoglutarate goes into the cell, and then you could exchange alpha-ketoglutarate for an anion, and that anion then goes into the lumen. At the bottom, you see how cations are reabsorbed. There's a net excretion of cationic electrolytes because you're pushing out 3 sodiums for every 2 potassiums that come in. So the net excretion of cations sets up an electrochemical gradient, which allows organic cations to move into the cell down the gradient. And then those cations are secreted into the lumen by exchanging them for hydrogen, for bringing hydrogen into the cell. So that's how cations and anions are actively secreted in the proximal tubule. So that's it for the proximal tubule, our workhorse. It's pretty much all downhill from there. The next part of the nephron is the loop of Henle. So you have a descending limb and then an ascending limb. There's not a lot to say about the descending limb, except that the thin descending limb is the part of the loop of Henle responsible for water reabsorption. So the thin limb is impermeable to sodium, but the interstitium down there is hypertonic in the medulla. So water is going to follow that osmotic gradient and leave the thin limb, and the luminal fluid becomes more and more concentrated. Then, back in your study guide, let's look at the thick ascending limb. The thick ascending limb is the site of the sodium chloride potassium cotransporter at the top left. You're actively reabsorbing sodium, potassium, and chloride. Now, back in the proximal tubule, it was more of a passive thing. Sodium came in with bicarb, sodium came in with chloride. But here in the ascending limb, you see that this is more of an active process, and you're actively reabsorbing sodium, potassium, and chloride. And the reason that the interstitium in the medulla of the kidney is so hypertonic is because all these electrolytes are being reabsorbed and put into the interstitium. So look at question number 8. What class of drugs inhibits the sodium chloride potassium symporter or co-transporter in the thick ascending limb? This is definitely important to know. This is the loop diuretics. This is the mechanism of action of loop diuretics. Now in the next video, we're going to talk about diuretics. We're going to see that loop diuretics cause an isotonic water excretion. So what else is going on in the thick ascending limb? At the bottom of the diagram, you see the divalent cations, calcium and magnesium coming in. They don't come in through the tubular cells, they sneak in between the cells. This is an induced reabsorption of magnesium and calcium. And one thing you also see about the thick ascending limb that you can highlight on the lumen side is that it's impermeable to water. The thick ascending limb is impermeable to water. But even though the tubular cells are impermeable to water, because you're reabsorbing all those cations, sodium, potassium, calcium, magnesium, what's happening to the urine concentration? Is the filtrate becoming more concentrated or less concentrated? Well, the filtrate's less concentrated, right? You have fewer ions, so the filtrate is less concentrated. Or another way to say it is that it's more dilute. So the thick ascending limb is diluting the urine. So again, the 3 things I want you to know about the thick ascending limb. It's impermeable to water, calcium and magnesium are reabsorbed here, and the sodium chloride potassium symporter is inhibited by the loop diuretics. Moving on then to number 9, which is the early part of the distal convoluted tubule. You have active reabsorption of sodium and chloride taking place here in the early distal tubule. And another very important thing to know about the early distal tubule is that it's not always impermeable to water. But the main thing I want you to know is that the calcium reabsorption in the early distal tubule is under the control of parathyroid hormone. So parathyroid hormone, or PTH, raises serum calcium levels by 3 main mechanisms. PTH stimulates bone resorption, it stimulates the kidneys to activate vitamin D, and it stimulates the kidneys to reabsorb more calcium from the urine. So this is where that takes place, in the distal convoluted tubule. Make sure you know that. Now we're ready to move from the distal convoluted tubule to the collecting tubule. And that collecting tubule name is a little misleading because it sounds like all we're doing is collecting the urine, and that's not at all true. There's actually a lot of action taking place in the collecting tubules. So before we get to the diagrams, let's look at question number 10, which says, what 2 types of cells compose the collecting duct and the last segment of the distal tubule? And what do? So there are 2 types of cells here. You have the principal cells and the intercalated cells. Now, principal cells have 2 main functions. They reabsorb water and sodium, and they secrete potassium. Then the other cell type is the intercalated cells. So intercalated means inserted or stuck in between. Hater's going to hate, intercalator's going to intercalate. So the principal cells make up most of the collecting tubule, but then inserted in between those principal cells you have intercalated cells. And those intercalated cells have 2 functions: to secrete either hydrogen or bicarbonate and to reabsorb potassium. So number 11 asks, what are the 2 types of intercalated cells? So intercalated cells come in 2 flavors. You have the alpha cells, or A cells, which secrete hydrogen ions, and you have the beta cells, or B cells, and those secrete bicarb. So you can remember B for bicarb or B for base. So some intercalated cells secrete hydrogen, other intercalated cells secrete bicarb. Then we have diagrams of a principal cell and an intercalated cell in your study guide. So we're going to look at the principal cell in just a second, but first I want you to take a look at the intercalated cell. Over here on the left is a hydrogen-potassium exchanger, which allows the cell to secrete hydrogen ions and to reabsorb potassium. So what type of intercalated cell is this? Is it an alpha cell or a beta cell? It's an alpha cell. A for alpha and A for acid. Then number 14 says, what determines how much water is reabsorbed in the distal tubules and the collecting ducts? So this is very important to know. It's ADH, or antidiuretic hormone, which is also called vasopressin. Now this is the diagram for number 12, and for the moment I want you to focus on the bottom half of the cells. ADH, or vasopressin, acts on the V2 vasopressin receptors on the principal cells of the collecting tubule, and it tells the cells to insert water channels called aquaporins into the luminal surface of the cell. And those water channels allow water to be reabsorbed. Now, that should look somewhat familiar to you. We talked about this in psychiatry because there's a drug we use for bipolar disorder that blocks the function of these aquaporins. Do you remember what that is? It's lithium. Lithium enters the cell through the sodium channels because remember, sodium is right under lithium in the periodic table, so they're chemically similar. So lithium enters through the sodium channel and it interferes with the aquaporins. We're going to see that again in a later video. So again, aquaporins are water channels that allow water to be reabsorbed. This means that the distal tubule and the collecting duct are mainly responsible for concentrating the urine by reabsorbing all that water, and they're concentrating the urine in response to ADH. So the thick ascending limb dilutes the urine by reabsorbing lots of sodium and potassium, and then the distal tubule and the collecting duct concentrate the urine. Now we're ready to look at the top half of this cell. Again, the functions of the principal cells, in addition to reabsorbing water, is to reabsorb sodium and to secrete potassium. And here at the top, you see the two channels that make that possible. Now question number 15 says, what class of diuretic directly affects principal cells? Well, it's the potassium-sparing diuretics. So lots of diuretics cause loss of potassium, and they cause hypokalemia. But these potassium-sparing diuretics don't do that. They're potassium-sparing. So if you inhibit potassium secretion in the principal cells, you're going to have less potassium loss. Now, not all potassium-sparing diuretics are created equally. We'll talk about them more in the next video on diuretics, but spironolactone and eplerenone are aldosterone antagonists that are classified as potassium-sparing diuretics because they prevent urinary potassium loss. But the other potassium-sparing diuretics, triamterene and amiloride, they work by inhibiting the epithelial sodium channels in the collecting tubules. They don't antagonize aldosterone. So number 16 says, what effect does aldosterone have on the principal cells and the intercalated cells of the collecting duct? And you can see this back on the diagram. In the principal cells, aldosterone causes reabsorption of sodium and secretion of potassium. Aldosterone causes your body to retain sodium and retain water, and at the same time you're secreting potassium. So if you have hyperaldosteronism, you're going to get hypokalemia plus hypertension because of retention of sodium and water. And if you were to inhibit aldosterone with an aldosterone antagonist, that might cause hyperkalemia. And then in the intercalated cells, aldosterone stimulates secretion of hydrogen ions. Well, we finally made it all the way through the nephron to the collecting system. And look, there's the golden treasure we were searching for. Now it's time for the end of session quiz. Now some of these are going to look fairly familiar because they're extremely important. We want to make sure you've mastered this before we move on and start talking about diuretics and how they work in a bit more detail. So answer those questions, then we'll go through them together. All right, first question. What segment of the renal tubule matches each of the following statements? The first bullet, reabsorbs 67% of the fluid and electrolytes filtered by the glomerulus. That's the proximal tubule. The site of secretion of organic anions and cations is the proximal tubule. Always impermeable to water, that's the thick ascending limb. Permeable to water only in the presence of ADH is both the late distal tubule and also the collecting duct. The site of the sodium chloride potassium cotransporter is the thick ascending limb. The site of isotonic fluid reabsorption is the proximal tubule. The site responsible for diluting urine is the thick ascending limb. The only site where glucose and amino acids are reabsorbed is the proximal tubule. And then water reabsorption in the loop of Henle takes place in the thin descending limb. Next, what are the two main cell types of the collecting duct? So you have principal cells and intercalated cells. Next, what drugs antagonize aldosterone's action on the principal cells of the collecting duct, thereby promoting sodium excretion and inhibiting potassium excretion? Well, these are the aldosterone antagonists, spironolactone and eplerenone. And the last question, what class of drugs inhibits the sodium chloride potassium symporter in the thick ascending limb? Again, that's the loop diuretics. All right, that's the end of renal 3. Uh-oh, kidney stone.